Thanks very much, Pablo, for inviting me. I think Pablo was hoping to get the three tenors, but instead he got the three Peters, Lamptey, Piot and Godfrey-Faussett, and probably you all have your view as to which of the three Peters is the least good singer. Certainly, it's me. I'm not actually working specifically on this. I'm the science advisor at UNAIDS, which means I cover a huge range. As Martin said, I started very much in the clinical TB HIV world and then got more into HIV, moved to UNAIDS, and was asked to cover a wide range of things, which has included NCDs. And it's meant that I've started learning more about the NCD movement. And I spend surprisingly large amounts of my time sitting in the UN task force on NCDs, which brings together the different UN agencies to sit around tables and talk endlessly about NCDs. We might think about some of the implications of that. But when I started thinking about this with Pablo and hearing what we should talk about, I ended up with this sort of graveyard slot at the end of the day. And I want to think a little bit about some of the themes that have come out during the course of the day, because I think much of what needs to be said and that I'm going to say has been said, but I'd like to bring it back, to re-summarize what's been said a bit and think where it takes us to. And it starts from the task, I suppose, I arrived with UNAIDS with regards to the NCDs, which is, we know this is important. You know, the HIV and NCDs overlap. There are big intersections. We need to work out what we should be doing about it. And it's often in those rather general terms that we hear about HIV and NCDs, and it often lacks some of the specificities that we've been hearing about today. And I'd like to spend the first half of my talk talking a little bit about some of those intersections, and rather like Peter, I've divided it into clinical, delivery and policy arenas. And then I want to move on a little bit to be not exactly a naysayer, but to reflect, which again we've heard a lot today, on some of the complexity, because HIV and NCDs, of course, disconnect in many ways, as well as we've heard, and the notion of learning the lessons from one for the other is a rather simplistic sort of bringing it together. I also wonder whether, from UNAIDS' perspective, sometimes we think we're learning the lessons in order to help people living with HIV, our primary client group, stay alive longer. And sometimes we have much more grandiose ambitions about using the HIV response to help the world be a better place when it comes to health delivery and health outcomes in toto. And as soon as we start getting those grandiose ideas, we often get a lot of pushback, quite rightly, from NCD communities saying, yeah, but we certainly don't want a UN NCDs. You know, there are many other ways of doing things. So reflecting on some of that. So on the clinical side, I think we are recapping, and so I can go quite quickly through this, that the reason that at the clinical level HIV and NCDs come together is largely due to our success in the HIV response in treating people successfully and allowing them to live on long enough for them to end up with the same risk factors as other people and developing NCDs. We've heard that there are natural history effects, and that HIV itself may stimulate some NCDs more and create more NCDs. And then we've heard there are pharmacological and pharmacokinetic specificities that we need to think about. Some of the antiretrovirals, particularly the protease inhibitors, do cause insulin resistance and may cause more diabetes directly through the pharmacology. And there may be important drug interactions that haven't been studied as much as they should, for instance, between the statins and antiretrovirals, that we know exist, but we don't really know what the clinical significance of them are, and how we should be dealing with some of those pharmacokinetic interactions. We haven't talked very much about shared risk factors. One of the challenges, of course, is that NCDs, as we've heard, is a dreadful term. Some of the NCDs are not even NC. They're perfectly communicable, like HPV, and that, of course, shares an important risk factor with HIV, that it's sexually transmitted. Other risk factors like smoking and alcohol are also associated with HIV, because we've always known that it's those people who know how to have good fun who end up catching HIV. So there are various things that come together in our understanding as to why, at a clinical level, HIV and NCDs overlap. I think there is another clinical point that Anne Johnson brought up in her chairman's comments, which was this business of the way that HIV has changed the way that clinical care is delivered. And this, I think, is extremely important. As someone who worked on the first HIV unit in London that opened in the UCL hospital, Middlesex Hospital as it was then, we saw a completely different way of dealing with our customers in those days. The first place that people would have fridges with their own food in, the first places that would have telephones available for patients, the first patients who you would actually talk to them about what they wanted in the way of their treatment, rather than leaving it to a junior doctor to give out the bad news in the cancer clinic or whatever. So I think that clinically HIV has led the way in changing some of the beneficial ways that healthcare is changing. Coming on to delivery, there are also many intersections in delivery, and as has been pointed out, and as Ian pointed out very nicely from his experience in Nigeria, you can go to many clinics, unfortunately, in Africa, and you can go to the pharmacy, and you can find the pharmacy well stocked with antiretrovirals and maybe TB drugs, and yet they don't have many of the drugs that should be there for treating many of the other chronic diseases. And why is this? Well, because HIV has developed a delivery system. And why was that needed? Well, because a lot of care, of health care, has traditionally been responding to acute events. So most of the care in resource-poor settings has been, I've got sick, I'm going to go to a pharmacist, a healer, a clinic, a hospital, I'm going to have a consultation, I'm going to get my treatment, and I'm going to go away. And I will never know what happens, the clinician will never know what happens to me after that. If I don't get better, I'll go to a different clinician because that one didn't do me very well. And so I'll shop around. And so the way that health systems were built up were largely around acute events rather than around chronic disease management. And I think that, first of all, tuberculosis, with the need to keep people on treatment for a long time, and maybe that wasn't the best way, using a sort of rather autocratic approach of trying to supervise people's treatment, but it allowed people to start thinking about actually maintaining longer-term care. And HIV par excellence has come along and said, well, actually, if you're starting treatment, that's treatment for life, which of course it should be also for diabetes and hypertension and epilepsy, but actually often isn't because the systems aren't set up nearly as well. So there are synergies and possibilities of learning. Nathan mentioned the public health approach and the simplification of reaching a system that, you know, this is just something that can be done, and that we try to make it so that you have a minimum package that actually can be delivered at scale to a large number of people. And again, that's an important lesson that has to be put out there. This balance between prevention and behaviour change. Johanna and various people have mentioned the fact that the global action plan on NCDs has very little treatment in it. You have to really look. The bottom two bars, you know, it said of eligible people, 50% getting treatment. And eligible means actually you've already had your heart attack. It's not primary prevention, it's secondary prevention, basically, in the global action plan. It's very big focus. And the reason for that is that, if you like, those are the health economists sit down and count the beans and say, well, this must be the cost-effective way of doing it. But I strongly agree with the comments, Peter, that you made, that actually, if you don't have treatment and prevention, you sort of lose the will to live, actually, if you're not dealing with the people who've actually got the disease. You can't make that link up. So you need both. And then approaches to behaviour change. On the one hand, this is a communality that, HIV, of course, has been working on those difficult areas of behaviour change and finding it difficult. It's a very different approach, though. Much of the behaviour change that we see in NCDs is seen as regulatory and even legislative, and rather than individual behaviour change. So many of the things that we've heard about of reductions in salt, of reductions in sugar, of smoking have been based around more regulatory changes, and that may be maybe a point for discussion. We've heard regularly in delivery in the aspect of community involvement, and this is perhaps across the HIV. If you really think about HIV, why did the HIV response take off? Well, it was because people with HIV got involved right from the start, went and invaded NIH and made them do research, went and demanded things, and that works. And we still don't see that same effect. And then we've heard about commodities and the sort of the fight and the way. That's another commonality, is to think about commodities. Intersections at the policy level, the two diseases that have had UN high-level meetings and declarations a decade apart, the two areas that make you think, well, we have to go beyond ministries of health, beyond WHO to get out there. and that's reflected in the NCD task force that I mentioned at the beginning, the notion of a whole-of-government approach and going beyond government to public-private partnerships. These are all commonalities between the way that the HIV response has been developed and the way the NCD response is developed. So there are indeed many parallels, and we can think then, well, what's been the fundamentals of the way that the HIV response has come along, and the investment approach is an important building block of the HIV response, to understand what's going on, to design appropriate things to do, to work out how to do those things at scale, and then to work out how you can sustain those and think of financing. And so this is just the sort of the standard way of presenting the investment framework for HIV from UNAIDS. And it has worked. One of the challenges that we've heard about again is difficulties in data systems. And in poor countries, unfortunately, vital registration doesn't exist in most countries. And so the data that we've seen that Moffat presented from the Africa Centre in KwaZulu-Natal, these tend to be from demographic surveillance sites that can show you a particular snapshot. South Africa is more unusual in having a vital registration system. So this is all deaths across the whole of South Africa from Stats South Africa from the vital registration system. And you can see that during the time, so it's very hard to point a pointer up here, isn't it? During the time from 1997 through to 2004, there was a steady fall in the median age at death. And then since 2004, it's gone up. So these are big changes. There's no denying that the HIV response has had a dramatic effect in countries where HIV is an important public health problem. And this is across the total population, not just looking at the people with HIV. And then we come back, and this is my version of Johanna's slide. This is the Global Burden of Disease study, and just putting the numbers of DALYs lost in 1990 and 2010 on a histogram in millions of DALYs lost, and seeing the overwhelming burden of NCDs. And I think that the reason, if you like, that we're here today is to think about, so why, where is this intersection? Why are we spending hundreds of times as much money on HIV as on NCDs? And where's that? What's happened? What did HIV manage to do, or why did it come about that we've had a response to HIV that's made the dramatic difference I showed you in South Africa, and yet NCDs, measured in any terms you like, really, are a far more significant problem in the world? And that's what I want to spend the second half of the talk just sort of reflecting on a little bit. So, first of all, I think that although we talk about the epidemic of NCDs have been with us always. They've been growing gradually, and they're getting worse, and they're rising. There's been a 25% increase from 1990 to 2010, whereas HIV, even though it looks much smaller here, has had an enormous rise, because HIV was a true epidemic that came along, and that was very, very scary. Anyone who was around in the early phase of HIV, this was a very scary, rapidly rising event that we talked about in terms of what it was going to do to whole societies, to populations, utterly different to the sort of gradual learning that NCDs are killing more and more people and taking away more and more years of healthy life. So I want to focus on the disconnections by focusing briefly, I hope, on these sort of areas. First of all, that non-communicable diseases are largely non-communicable. And that's very different. It's utterly different in terms of the externalities and of the risks to other people, that we're not so interested in controlling NCDs to protect ourselves, if you like. The threat of multi-drug resistant TB is very immediate to people, even though it's not killing very many people, because I might breathe that in and catch it. So that has a very different sort of resonance in the world. The unexceptionality of the NCDs, which we'll come back to, but rather perhaps the exceptionalism that went around HIV and where that came from and what that caused, and then some issues around politics. So I think, again, we've heard a lot of these things as we've been going through. I've mentioned the fear and the feeling that HIV could even be a security issue. HIV was also much more coherent, because HIV is a single virus, well, multiple different clades and types, but essentially very simple. And there are simple ways of catching it, complicated perhaps, but nonetheless quite simple. Whereas NCDs actually covers a huge range. Even in this meeting, we haven't had a single clear definition of which diseases we're talking about. The Global Action Plan doesn't talk about mental health. We've got communicable, non-communicable diseases. So we're sort of, we sort of lump various things together. Cancer itself, many, many different things, each with their own different responses, different things. So it's not surprising that it's much, much harder to come up with the single plan that Peter was talking about of why HIV was able to say, this is what you do. Because NCDs cover such a wide range that essentially we're saying, how do we deal with chronic ill health and what are the systems that we build for that, which is very, very different to a single disease. So that's the coherence complexity story. We can argue, and perhaps I won't spend time now because we'll run out of time, but we can come back to the provocative statement that Peter made about vertical versus horizontal and exceptionalism and the sort of benefits of an exceptional disease and being made exceptional. But HIV has been exceptional. It's been, you look at the rates of change that have gone on, you look at the engagement of people living with HIV, you look at the politics around it. Part of that comes from the activism in communities and so on. How do we make any of the NCDs exceptional in that way to generate the enthusiasm politically to put weight behind it and money behind it? And I've mentioned that it's been a much more incremental process to get us to this horrible state that we're in. The populations affected, it happened that HIV started off in Africa, but also in the US, and it started off in the US affecting the gay population who already were politically active and trying to organise and already felt, rightly, that the world was somewhat against them and that they'd sort of organised politically in various places. So there was a sort of a feeling of we can change the world. We have changed the world in some parts of America, that we've made people accept this. And so the emerging out of that gay political movement that then spread to other places, a very, very different feel to the way that we find with people living with diabetes, for instance, who just don't have that sort of that political push. And I think that that has then spread to involve other people, so that the principle of involving people with HIV in everything about HIV is very fundamental. And it's spread somewhat to TB, and we've seen from the HIV-TB nexus that we do now have activism at TB meetings with people living with HIV or TB coming and speaking out to it. Social justice and human rights were deeply embedded in that, and we saw Tim's slide of the difference between death rates and the reason that the Global Fund and the optimism at the Millennium for saying it can't be right that people just die at different rates when we've got drugs available and that these death rates happen. And yet we're allowing that to happen for NCDs all the time. So somehow we're not making those points in a way that brings it there. And then we come to this tricky issue of competing interests. For many governments, they've got one part of their government that is trying to ensure that trade goes well, and that includes palm oil and tobacco and processed foods. And they've got another part of their government that is saying, yes, but we need to be stopping people dying from NCDs. And sometimes those two halves, even in the same government, are doing diametrically opposed things in terms of bringing down rates of NCDs. So we have this, that exists much, much less in the HIV world, that it's not, no one is really promoting the very causes of the problem, of the risk factors. And I've mentioned then the externalities of transmission, and that dealing with HIV prevents ongoing spread of the disease and the spread more widely. So, I could take any of those points somewhat further, but I think I was really just trying to sum up some of the things that we'd heard about a bit today to focus the discussion a bit, really, and give us somewhere to go. As we go on, I think we have achieved enormous things in the HIV response. It's really important that we don't draw back on that, because we'll lose ground very quickly. We know in most communicable diseases, if you withdraw the response in malaria, in TB and other things, you get a resurgence very quickly. We've made good ground, we've saved millions of lives. For goodness sake, let's not lose what we've got. There are lots of intersections between HIV and NCDs, and we've brought some of those up in today's meeting. We need to build on those. But I think it's really important to recognize that there are also many, many disconnections, and not to be overly simplistic. At its most dangerous, people say, well, we can treat ARVs in chronic care situations, so we just treat all the NCDs in the same way. But we've heard that there aren't enough human resources, that actually the people living with HIV make up a small proportion, even though it's a big disease, but make up a small proportion of the total population. So it's not plausible to think that the sort of Rolls-Royce care that some patients with HIV get in Nigeria, for instance, could really be applied across the whole of Nigeria to all patients with diabetes. I don't think. So I think we have to be realistic and recognize some of the differences. I do think that the investment thinking that UNAIDS has been pushing is a useful model, particularly the notion of delivery and sustainability, that we have to be able to scale up. We have to pick simple things that are the right things to do, whether they be at the population level, at the community level, or at the treatment level, simple things that are easy to understand, that are certainly the right things, and find ways to scale them up to affect large numbers of people, millions of people, billions of people even. And if we do that, I believe that we can achieve coverage, and data has been mentioned a few times. We need to be able to measure impact, which means having data systems that can deal with that. Thank you very much.